We're waiting on a quorum. Go ahead and turn your cell phones off. As we wait for one more member, we just got out of the Republicans just got out of a caucus meeting. What do you mean if they don't pass where? Thank you. And thank you to the committee members. The first one I'm going to take right quick is House Bill 937. And I'm going to carry this bill. Representative Williams told me that it was all right for me to say that she has gone for a checkup with her oncologist. If you will remember, she testified and had suffered from breast cancer, and that's what motivated this bill. We passed this bill out. 937. I knew it was too easy when the insurance representative said what we had was fine, no problem whatsoever. And so it went to rules and it got sent back. So if you will look on line 11, it's just a different kind of explanation, and it sets a end or gives the physicians when they want to end a patient's need to receive notification for a mammogram. And I'll be glad to answer any questions. There was not an ending on the other one. Are there questions from the committee? Okay, Representative Hogan.
Motion do pass.
Okay, I'll go ahead and take that motion to pass. And second, is there other questions from the committee? Seeing none, everybody in favor of the substitute to House Bill 937, say aye.
Aye.
Anyone opposed, no. And we will certainly hope that Representative Williams gets a good report today. She was so committed to it, she wanted to cancel her meeting and her appointment, and I said, absolutely not. Okay, Representative Barton, you got about 3 minutes to present House Bill 1483.
This is House Bill 1483, and the LC number is 338981. And this bill, the first changes in the bill, it's lines 50 through 53. And this is where it allows a licensed social worker enrolled in the master's program to become an LCSW. That's a licensed certified social worker. This will help speed up the process for licensed social workers, allowing them to start while they're still in the program. Line 62 through 66 provides that the board shall issue reciprocity for endorsement as long as it allows, as long as the other states have the same stringent coursework that Georgia has, and that will help get more people into the field here. The third major change it's lines 81 through 89. And this is where it helps speeds up the other part two. It changes the amount of time that a social worker needs to have a supervised experience for the master's level from 3 years to 2,000 hours, with only the first 1,000 hours being under direct supervision versus 2 years. It changes one year requirement for substitution in related field to 1,000 hours. These changes increase the workforce for the mental health profession. One of the things is the 3 years full-time prohibits, in case something happens, like a family emergency, someone gets hurt. And if you do that, you have to start the clock over again. And this, having the pause in the practice, this will make it to where they could continue on, even if it takes a little bit longer to get your master's. And then lastly, the Section 5, it encourages the board to review their rules and regulations to help streamline the process to get more people into the field of the social work. And the reason why it's important too, that if you get your master's degree, you can work by yourself and then get other people to work with you. So this will help get more people in this field.
Representative from no. Okay, and the reason for these revisions is that these come from the rural
Through
The
discussions
rural-
with the rural development.
Rural Development Committee, because people began to talk to us about the differences between the states on how many hours that the students have to put in before they can get their full license or work independently. And there was quite a bit of discretion. Some places, had 4 years on certain areas, and some had 2 and some had 3. So this is from a review of that. So reducing this to 2,000 hours instead of 2 full years. And we're trying to get more people out in the field, not to have them less qualified, but to streamline the process, especially as we put the new mental health bill into work, into a reality. Representative Hutchinson.
Thank you, Mrs. Chair. I just wanted to say that this is a phenomenal bill. I'm glad that it's being brought forward, and thank you to the author. One of the things that this is really going to help with is right now they have to, social workers have to have 3,000 hours. And if you're not in a job position where your immediate supervisor is a clinical social worker, then you have to, in some cases, have to pay hourly, sometimes around $65 an hour for 3,000 hours. And if you're a social worker, that's usually your salary just doesn't allow for that. So this is a phenomenal bill and I support it wholeheartedly.
Representative Hutchins, you're saying that to get supervision, you have to pay another social worker, a fully licensed social worker, $65 an hour to supervise you so that you can make those 3,000 hours?
Correct.
Ooh, okay.
Yeah, it's around 65. That's about the average.
Okay. Sometimes I think I'm in the wrong business and go back to supervising nurses or working as a nurse in the hospital at $150 or $200 an hour.
Well, or you can work for someone like me and then you don't have to pay because I am a licensed clinical social worker. So there's that.
Okay. Do we have anybody that wants to? Okay, wait a minute, Hogan.
Pass.
Okay, hang on just a minute. Do we have anybody in the audience that wants to speak to the social work bill? Nope, seeing no. Okay. Representative Bennett, you have a question.
Line 100, can you just explain what that means? Line 100 shall stand repealed by operation of law on December 31st, 2022. Just that one section that they have to revise, they have to create. Okay, thank you.
Okay, any other questions from the committee? All right, Representative Hogan, we're ready. You do move. Okay, this is House Bill 1483, LC 338981. I have a motion that do pass. Do I have a second? I got a second. Everyone in the favor of the passage of House Bill 1483, say aye.
Aye.
One,
Aye.
say no. Okay, the ayes have it. Okay, Senator Kirkpatrick. Let's do Senate Bill 340 first. Okay, everybody got 340. It's Senate Bill 340, LC 338974S.
Thank you, Madam Chair. This bill was brought to me by the Georgia Board of Healthcare Workforce. Unfortunately, we lost the director, LaShawn Hughes, a few months ago. And she was passionate about increasing healthcare access in rural Georgia by improving our supply of physicians and other healthcare professionals. This bill does two things related to residency training programs for physicians. First, it corrects the language that's in the current code, which says AMA, but the AMA actually does not accredit residency programs. It should say ACGME. And so this bill corrects that agency. The second thing it does is it removes the size requirement for residency programs. Our current law says that you have to have 50 residents in your program, and the rural hospitals just can't get there. The ACGME doesn't require any minimum size in order to accredit a residency program. So this should make it easier for hospitals in rural Georgia to develop residency programs.
Questions for the senator? Once again, any questions for the senator? Is there anybody in the audience that would like to speak to the bill? Wow, we're on a roll. Okay, we've got to move, do pass in a second. Is there any further discussion or questions from the committee? Okay, hearing none. Everyone in favor of the passage of Senate Bill 340, LC 338974S, say aye.
Aye.
Oh, say no. The ayes have it. Okay, Senator Kirkpatrick, go to your next one, Senate Bill 341.
Thank you, Madam Chair. Senate Bill 341 is a continuation of the conversation about prior authorization that we started last year with Senate Bill 80, which, as you probably recall, passed both chambers unanimously on day 40. And what that bill did was add transparency to the prior authorization process for patients, physicians, and hospitals. Part of the process of getting this bill passed was removing some language about medications for people with chronic conditions. I committed to meeting with the stakeholders during the off season to come up with a way to make progress on that issue. We had several meetings, and the result is this bill, which is modeled on a Kentucky bill. And the essence of the bill is that a patient with a chronic condition who's stable on medication would only have to go through prior authorization for that medication once a year. The prior authorization could be longer than a year, and that does occur frequently. And there are some exceptions where the bill would not apply, including drugs for non-maintenance conditions, meds typically used for less than 12 months, meds for which the science does not support a 12-month approval, including those where the patient may need to be checked earlier for side effects or response to the medication. And the effective date of this legislation is January 1st of 2023. And I really appreciate the willingness of all the parties to work together to try to solve this problem for patients with chronic conditions.
It's for the senator. Okay, all right. Representative Newton.
Thank you for the bill. Just curious on line 28, where it says the last day of coverage under the covered person's health care plan. So if they change plans, didn't we have a bill earlier on step therapy that, or on therapy that didn't require them to go back if their employer did change, from one plan B to plan C, that didn't require them to start at ground zero? That was an earlier bill, I believe, of yours. Is that correct? Or was
I
it-
carried that for the chair lady, and I think that applied to changing plans within the same carrier. But if you change plans outside of a contract with one carrier, you can't bind a private contract. And so if people changed plans within the carrier, they should be protected. And the insurance industry may want to comment on that. But obviously, if you terminate your plan, then
Right, there's
all
no-
bets are off.
And it doesn't bind the new plan.
Right.
And we're not changing anything in this bill that happened previously. I guess we didn't have any protections if you change from plan B to plan C in a different carrier.
Jesse. Jesse, is that the way it worked? I've forgotten what the bill did. I know that if you had failed, I think there was something that if you had failed on something a couple of times already, it's amazing how you think you're going to remember all your bills, but
Yes, ma'am. I think the question was around the step therapy bill that y'all did a couple of years ago. That may have actually predated me in this role, but your question, Representative, related to transitioning a carrier, that was in SB 80. That was addressed last year as well. So this wouldn't do anything to change that. I'm signed up to testify on this bill. I can go ahead and tell you that we are in favor of Senate Bill 341. We appreciate the senator convening all the groups and working with us over the interim. I think that's the right way to approach an issue like this, which gets pretty complicated.
okay. Do we have any other questions? Okay, we have several people that want to speak on the bill. Whitney Griggs.
Hi, I'm Whitney Griggs. I'm the health policy analyst with Georgians for a Healthy Future. Georgians for a Healthy Future is a nonprofit focused on making sure that all Georgians have access to quality, affordable health care. And I'll keep this very brief. We are very much in favor of this bill and the benefit that we'll have for the Georgians that suffer from multiple chronic conditions like diabetes, pulmonary disease, heart disease, and being able to stay on their prescription medications for as long as possible, which is oftentimes the most effective medically and cost-effective way to treat these conditions. Thank you.
Melissa Ryholt.
Hi, Chairman Cooper and committee members. I am Melissa Rybold with the Georgia Pharmacy Association. I'm the VP of Public Policy, and our member pharmacist and GPHA supports any legislation that allows easier access to medications for patients. So we appreciate your favorable consideration on this bill, and thank you for this bill.
Thank you. Greg, are you team covering this one?
Thank you, Madam Chair. I'll be brief. Greg Rybold on behalf of American Pharmacy Cooperative, and we do believe that this legislation will increase access to care, improve adherence to care, and also remove bottlenecks on the provider side for physicians, prescribers, as well as pharmacists. And so we're strongly in favor of the bill. Appreciate your favorable consideration, and thanks, Senator Kirkpatrick, for bringing the legislation.
Bethany Sheriff.
Hi, I'm Bethany Scherer with the Medical Association of Georgia, and we're here in support of this bill. And thank you to Dr. Kirkpatrick for your continued work on removing some of the administrative burdens that prior authorization can bring and some of the delays to patient care and patient safety issues that can result from it. I do want to answer the question about step therapy. The step therapy bill did allow for an exception to step therapy protocol that would in some ways bind a new plan.
Yeah.
It's just a little bit different than what we think of with prior authorization, because prior authorization is like an affirmative, we will cover this service, whereas the other is just an exception to a protocol you might have to get through before you get to an already covered service. Hopefully that helps.
No, it does. Thank you very much. I thought that Representative Newton, I thought we were right on that.
Yes, and
But-
SB 80 does contain some language that if you're switching kind of like your plan within the same insurance carrier, it would apply. It just doesn't apply if you're switching from, say one insurance carrier to another.
But hopefully they would consider it even if you went and said, I failed. Hopefully, it didn't mean it, they
Ho-
have to. but-
Hopefully that would shorten the process a little bit if the physician has some data to show. But I will say that a lot of times the initial step there, initial prior authorization, denial is done kind of by just a automated system. So it's not like somebody looks at that and can see that you've used that medication before. So
But just like in the regular bill, it was a way to go back at them to get an exception to it. So
it would probably be helpful
To
if
try.
you appealed a decision to deny it and you were on a phone with your peer, with the peer review situation, but yes.
that's
Thank
it.
you.
Thank you very much. Okay, we're back to the committee. Anybody else come up with a question or anything for the senator? Anybody online? Nope. Okay, we're ready for a motion. Okay, we got a motion, do pass in a second.
Second.
Everyone in favor of the passage of Senate Bill 341 LC 520066S, say aye.
Aye. Aye.
Opposed, no. The ayes have it. Thank you, Senator Kirkpatrick. I'll sign these forms and turn them in for you since. Sure, and who's carrying the other one? Okay, will you remind me which ones you're doing? Okay, thank you. All right, we have Senate Bill 403 and welcome to House Health and Human Services. Senator Watson, is this the first time that you've been here?
I think I may have been here a
Long
time or
time
two in the
ago?
past.
What
Well,
time is it?
certainly.
I'm sorry.
Certainly 8 years ago, but, may have presented a bill here a time or two.
Yeah, I know I get to come see you, which is always, so far has always been a pleasant thing. So
Well,
thank you very much. We'll try to
we
make it easy on you on this one.
We aim to please. I'll be brief, but I want to be thorough too, in that I did bring Judge Sweat with me, who is a judge in Athens, Clark County, and has been instrumental in this. And so Senate Bill 403 is a bill about co-responders. And as you may know, we have about 6 co-responder units in the state of Georgia. I'm fortunate in that Chatham County is one of those places. It actually was the first place that had the co-responder unit, followed by Athens, Clark, very close second there. And Judge Sweat has been very helpful, and if I may say, has been very instrumental in getting this legislation to where it is now. The other places that do have it, it is in Forsyth County also. Gwinnett and Rockdale and one other county do it in a joint way. Carroll County also has one, and I think maybe Fulton has one too. Did I miss any? Fulton, Cobb. And Cobb. So there are about 6 places that have this going on, and we're using them as an example of what we would like to do in the future and take this to the rest of the state. So what are we taking to the rest of the state? We're taking a crisis response, post-crisis support services, a jail in-reach aspect relating to this. We hope to enhance public safety through these responses to behavioral crises, de-escalating the behavior, diverting individuals who need treatment away from jails and prisons, decreasing cost incurred by county jails and criminal justice system, and increasing community access to behavioral health services, along with reducing recidivism. So it is it's a simple concept, but it's a rather complicated thing to implement. What has been done is through the community service boards, which is part of DBHDD, Department of Behavioral Health and Developmental Disability. So mental health and intellectually delayed individuals. So that is what that is responsible. And the community service boards are part of DBHDD. So what we're doing, we're requiring community service board to provide the framework or the infrastructure relating to that. And then if law enforcement so chooses, not required, but so chooses to join them in the community service boards, then to form a co-responder unit. Now, there are a lot of details related to this, but that is the big concept that we want to stress today. Community service boards required to set it up, and law enforcement has the option of doing that. Now, if you think about it, law enforcement would certainly be incentivized to do this because they don't want to go out and arrest the person. I'll use an example in Savannah, attempting to jump off a bridge or jump in the Savannah River. They don't want to arrest that person, take them to the emergency room, and then take them to jail. They want them in the appropriate place, which would be a crisis stabilization unit and so forth. So that's sort of the big picture. I'm going to turn it over a little bit more to the details related to Judge Sweat, and then we're going to circle back. We have about 3 or 4 people to testify by Zoom and or by video, and they can drive the point home a little bit better than I, because they are actually the ones who are boots on the ground.
Thank you, Senator Watson and Madam Chair and members of the committee. I appreciate the opportunity to be with you today. You have co-responder teams have become a national model for addressing and effectively intervening in circumstances where individuals may be experiencing a behavioral health crisis. And what we have found is that the presence of a behavioral health person with a trained law enforcement officer will de-escalate crisis, reduce the frequency and severity of needing force to work with someone in a crisis. It prevents injury to the officers or individuals, and then following that connects them to services and avoiding additional episodes where they may come into contact with the criminal law. What we found is that these co-responder teams will reduce the amount of time that officers must spend addressing situations that with individuals who are in a behavioral health crisis. And it also, and maybe most importantly, we are deflecting individuals away from our jails and from our emergency departments and emergency receiving facilities. And whether the data varies from program to program, but 80 to 90% of the individuals that are encountered with the co-responder team are going to be deflected away from arrest and away from an emergency receiving facility and connected to care in the community. We think 403 is the way to do this because it builds on the existing infrastructure and it is a community-based solution. It'll be the community service boards will work with their law enforcement agencies in their service area to develop the plan and partner with the agencies to develop the co-responder teams. And it kind of gets a real laser focus on how this can be done with what is already existing in the state. It doesn't just provide the emergency response, but it directs that community service boards do a crisis follow-up. So within 2 days of an individual having experienced a behavioral health crisis, that they can be seen by community service board representatives and trying to engage them and get them into treatment to prevent recurrence. The other thing that is in the bill, it's very important, is it adds the piece of jail in reach. We know that that our jails have become essentially the depository for individuals who have severe mental illness, and this will allow or direct the community service boards to work with the sheriffs to identify individuals who are in jail have severe mental illness, and to, if appropriate, direct them to community treatment that is more effective and keeps down the expense. We think this is a public safety bill. We think it will increase public safety, hopefully reduce the incidences of tragic outcomes and save money, both in terms of jail costs, but also officer time and the time that is spent dedicating to these things. We know that most 911 calls are not calls for investigation of a criminal matter. They are calls where a circumstance has arisen that someone is in crisis, and often it's a family member. And having a skillful and effective response to those calls will improve our outcomes for all of the individuals involved. We have 4 speakers, 2 by Zoom and 2 in present. One is first start with Major Robert Gavin, who is the behavioral health unit supervisor in the Savannah, the Chatham PD. Then we'll hear in person from Tammy Conlon, who is the executive director of the Advantage Behavioral Health, which covers Athens and surrounding communities and has been working with the co-responder teams for several years now. And then we'll hear from Cindy Levy, who is the executive director of Avita, which covers Northeast Georgia, works with Forsyth and is starting to work with other counties. And then we'll hear from, if Madam's patient with us, Sheriff Ron Freeman from Forsyth, which has existing co-responder program.
Well, I have a question first. Yeah, I've been lucky enough to talk to you and to have seen one of the co-responder partially. I got to see sort of the end of it functioning, but I don't think all my committee people have. So could you actually walk us through? The call comes in and somebody is sitting on the side of the Savannah Bridge that, threatening to jump off, what happens?
Well, typically before you would have 3 or 4 patrol cars with uniformed officers that are trying to do what
Talk
they
'em down.
can to talk them down. Well, that's not necessarily their background or training. What we do is get a trained police officer who is also trained in crisis intervention training.
So the call
with-
goes where? The
If
call goes,
comes in from 911. Usually our co-responder teams may not be necessarily the first unit on the scene. They're probably coming along after a unit has determined that it is appropriate to get in the co-responders. Can be sometimes determined by dispatchers. In Gwinnett County, they're doing a great job of starting to develop that ability to dispatch the appropriate call from the time of call to 911. But the co-responders are going to arrive. They're going to be an unmarked car. They're going to be dressed in civilian clothing, and they're going to be able to begin to engage, hopefully in a language that is going to be more effective in reaching the individual who may be in that crisis.
will that be a one person, two
It's-
people?
Typically, we have 2-person teams of a trained law enforcement officer and could be a LCSW, LPC, possibly a psychologist, but a licensed person that can do an evaluation of the situation and begin to form a response that they can implement.
All right, they would talk to the person.
Yeah.
Okay, and
Hopefully, they're going to get them out
Off
of
the wall.
crisis. I mean, it's the bridge is the dramatic thing. And our co-responder in Athens has talked someone off the edge of a parking deck and went up on a fire ladder to do that and got them back safely. But a lot of times you have people that are in behavioral health crisis that are just acting in bizarre ways. They may be running in traffic. They may be doing things that are offensive or scary. And a lot of times that's bringing in that same team to kind of de-escalate that situation and then try to determine what kind of resources that individual may need. Do they need to go to a place of treatment with a 1013? In some instances, that's true, but they certainly don't need to be arrested. And we can most often direct them to other community services that are going to meet the needs and hopefully prevent the recurrence. But it also frees up. If you've got 4 officers sitting there trying to figure out what to do, the co-responder team can show up. Those other officers can go back into service. And the co-responder team can deal with that. Is it effective for police activity?
okay, does this allow if, on 3 to 11 or 11 at night to 7 in the morning where you might not have a social worker or a psychologist or so forth, does it allow the trained police officer to go out?
Well, the police officer can go out and we're going to be looking at how we can provide virtual backup.
Okay,
Some communities have actually situations where they've got a 24/7 virtual backup. I've got an iPad or some other device where they can bring the behavioral health person into the conversation. It's going to be hard developing this is going to take a couple of years. It's hard to get behavioral health folks as it is, but the ones that get into it are very excited about it. But having 24/7 is an aspiration.
So, Major Gavin, who's online, I think with us, hopefully, should be able to actually take us through maybe a run or two.
okay,
that
we've
can
sort of got
take
the
each other
idea
data.
now, I think, to the committee. Okay. Representative Hogan, can you wait or you want to add? Oh, it's Representative Kelly.
Ask a question if I could. Thank you, Madam Chair. And I appreciate the work that's being done on this, co-responder model. I think, we've talked about it extensively with the mental health bill that we have over here, and certainly something that we've tried to work and advocate for. So this seems to make a logical, it makes sense to be a logical step in the process. My question kind of through the whole thing has been, are there a list of offenses or scenarios where if a call comes in that you're going to do a co-responder model on, or do y'all just kind of make a judgment call on each and every one?
So, I'll answer this from what I've learned, and Judge will be able to give a little bit more practical, and Major Gavin will too. But the dispatcher should be trained, right? And that should be a piece of the puzzle. So if the policemen are there and 2 or 3 units or 1 unit, then, and they realize this is more of a behavior crisis issue, then they would be calling in the co-responder unit. So it's either done at the dispatcher level or the local level. And I think, with the training, then that should be pretty easily to ascertain. I mean, most of the time, these are more frequent flyer people that the crisis intervention team and the behavior crisis center will know, as do the police officers. This is not in a vacuum. There should be good communication.
And that's where I was just trying to figure out, obviously, when someone's looking at, committing suicide, that's someone who certainly needs to talk to a mental health professional, someone that needs help. Then I'm trying to walk through just other scenarios in my mind of if it's a domestic violence situation. I would think someone who's, beating their wife has some mental issues they need to deal with.
Someone that is involved in domestic violence very well needs some interventions. This is not designed to address that topic because it just is beyond the scope of, that's too complex a problem. And I mean, the individuals that are doing co-responding are building a framework that can then go forward and to connect people to treatment. And so more likely you're going to see situations where somebody is acting in a bizarre way, or it may be an unwanted person. When we talk about familiar faces, there are a lot of folks that they just are known to law enforcement. They're known to the behavioral health community. They're kind of constantly having encounters with law enforcement, frequently arrested, often taken for treatment at a mental health facility. And this fairly small percentage accounts for a huge number of our jail admissions and hospital admissions. So it's not so much the domestic violence, it's more some of the other varieties. It's people that might be psychotic or experiencing other kinds of psychiatric breakdowns.
I was a municipal solicitor for a little while, and we had individuals every time the court was open, and they were individuals who I think you're describing there. So thank y'all for helping me understand. Thank you, Madam Chair.
Thank you. Okay. Representative Newton.
Thank you, Madam Chair. A couple of questions I did see on line 118 about each community service board shall establish a co-responder system, shall require a written list over 147. And then you said there's like 5 or 6, I believe, and then but maybe 25 community service boards in Georgia. Is that?
I can actually, and I've got an updated count on that because this weekend I should have done this months ago, but there are 9 community service, there are 23 community service boards at present. There are 9 of them who have developed co-responder relationships with about 15 or 17 different law enforcement agencies. Of course, we have over 700 law enforcement agencies in the state of Georgia. So we're just beginning this, but we've got the framework. The Community Service Board has to establish the program and set up a co-responder protocol committee. The law enforcement is required to have a representative go to that committee so they can start working on how they're going to more effectively respond to individuals in a behavioral health crisis. Law enforcement is not compelled to have a co-responder team, but we're hopeful that, and what we have found is that when law enforcement and behavioral health folks start collaborating around particularly these familiar faces, that they realize they're serving the same individuals and they can serve them effectively when they serve them together. So we're starting this. We've still got some work to do to reach areas because Georgia's a big state. We have to find a model of reaching rural areas. That may be where technology, it has a piece in here that allows for virtual contacts because we know that there are times when there may not be someone who can be there in person, but if we can have them virtually in person, they may even have a dialogue with the person over an iPhone or something, iPad or something, with the individuals in crisis, trying to sort things out.
If you don't mind, I love the options. I guess it means there was 23 and only 9 have them now. So we're going to expect the others. And then I did notice you mentioned Cobb and Fulton, which have resources that maybe a lot of Georgia don't have. I noticed on line 246, everything's contingent upon appropriation by the General Assembly or other funds. How are they generally funded now?
Right now, it's the recent expansion
CSBs.
And it has gone up quite a great deal. I mean, CSBs are on a state budget item, but these programs have basically been started with grant funds. Some of them have been recently started with COVID funds. We've got to have a sustainability, a way to have sustainability for these things And some of them have sort of started on a wing and a prayer and tried to fit things together. One of the things about our community service boards, they're on a fee for service basis. This type of service is not, it's not really susceptible to payment on a fee for service basis. We got to pay for it in advance. Then we can get people into our systems and start treating them in community service. board.
Just to follow up on that is that in Chatham County specifically, there was a grant and then there was appropriations from Chatham County. As you can imagine, less people in jail, the less it's going to cost them. So it is a cost savings measure with an investment.
Did you want Dr. Johnson to go first or Major Gavin?
I think Dr. Johnson may have had to leave us. If he's still, if he's left us, then maybe Major Gavin.
How do we tell? Dr. Johnson?
Is Dr. Johnson there? No, I didn't. I think
Okay, he had to go.
another-
Okay, then. Oh, he is online.
If we can hear briefly, I realize y'all's time is very valuable.
Yeah, but
particularly
this is,
before
so
crossover
this
days.
is important, Judge. We'll try to get the other chairman on the other side my cohort from the Senate side out in time for his committee, but this is important.
Thank you.
Okay, Dr. Johnson, you have the floor.
Thank you, Madam Chair. With your permission, I'll share 3 brief slides. They give the background for this effort. Let me pull them up right now. Well, here we go. We did indeed start here in Chatham County. I'm gonna have to stop sharing for a minute. We started this effort 4 or 5 years ago. It began with partnership, the mayor's office, Savannah Police Department, the sheriff, and myself all went to a meeting up in Washington, D.C. with a number of cities that were beginning to do these kinds of efforts. And from that, it has evolved over time to some grants. Major Gavin can speak to the immediate funding right now, but it's been highly supported and funded indeed by the county as well. Here we go. Slideshow. This is a tool, if you haven't seen this model, breaking the cycle, the sequential intercept model, has really focused the discussion across the state and across the country. We would get together previously and talk about where does law enforcement need behavioral health, and there would be the various issues of people that did not need to be arrested but needed help and often ended up arrested, people coming out of jail. But the sequential intercept model has really helped focus that discussion. So though all of the partnerships don't occur between intercept 0 and 1, most of them do. The goal here is a pre-arrest approach. The mantra is to do the right intervention by the right team, and this bill creates those teams, to the right place. So it may be to a crisis behavioral center, it may be to an outpatient center, it might be to drug treatment, but the outcome that everyone's after is based on the true need of the person. One of the big strengths that the partnership brings is continuity of care, so that an individual can have a warm handoff if they need case management, a peer program, outpatient treatment, or any of the supports that help with continued recovery and decreased recidivism. And those are provided by the community service boards. And you can see here, we've got the co-responder team and telepsychiatry, same-day crisis counseling, respite care, outpatient clinics, ACT teams, which is a hospital without walls, and our behavioral health crisis centers in the state. So that's kind of the context of how this got rolling and how it's embedded with community service boards. A very important point before I turn things over to Major Gavin. We find these things are very, very local. The needs are local, the resources are local, and so it's really works best that it's one model in terms of the big picture of what we need, the co-responder teams, but the actual local model varies by municipality, by county, by part of the state. And so I think this bill is very well drafted because it allows the parties to get together that can then discuss what do we need, how do things work locally. Thank you very much for letting us present today. And if I may, I'll turn things back to you, and Major Gavin will say more about what we do in Chatham.
Oh, Dr. Johnson, just a minute. Thank you very much for testifying. Does anybody have a question for Dr. Johnson? No, I think you covered it. Is it possible for you to send those slides to my office, and I'll give them out to my committee members as this bill before, it gets discussed, because it's going to rules and then the floor.
Absolutely, Madam Chair. Thank
Okay.
you.
Thank you very much. And I think you hit a really good point that it certainly does the framework, but that having it fit locally is so important. Where Savannah may be able to offer 7 different types of service, somewhere in rural Georgia may only have 3 options. So it does have to fit. And I think that's a really important part of this, to look at this program. Thank you, sir. Go to, and Major Gavin, if you will take over. Thank you, sir.
Madam Chairman, thank you. And thank Dr. Johnson. His collaboration with our unit has been the reason it's here and the reason it's functioning. And, he worked with us a lot of time in the beginning to get this on board. We did launch in September of 2020. We worked up to it by collecting a lot of data that came from what our officers were writing calls on. And just an example, we had over 5,000 calls that were specific to a mental health designation or signal that officers were dispatched on. But we soon realized that there were several other thousand that went out as a disorderly person, as someone in traffic, and it was not as a, and so we started realizing that those calls were very high. And so we were looking at a lot of the repeat offenders and pieces like that. And so when we created the unit, we specifically went after identifying who could be helped, outside of going to jail, and getting people into the services that they needed, and that warm handoff that Dr. Johnson spoke of. So the unit itself, since we've started, we've had hundreds and hundreds of intercepts, but we've specifically dealt with 223 individuals. And of those 223, we've completed follow-ups, which are, the secondary step after the initial response. This is with a clinician, maybe 2 days down the road, 4 days down the road, or after they've gotten out of treatment, and tried to keep them on track and help them move forward just by checking in to see if, things are going well, if they're getting their medications, are they having problems with transportation, things like that. And we try to come up with solutions for them. We've connected 164 people with services outside of, taking them to an actual crisis center or getting them in touch with, whether it's outpatient needs or alcohol or drug intervention type help. But the key part of it is, of all of the people we've dealt with, only 21 of them went to jail. And of those 21, most of them either had warrants or pieces like that we weren't able to allow them to go. They had to go into the jail and be processed. But I think over the first year, we went from having 87 or 88% of the people we dealt with going to jail. And that was actually flip-flopped to where it was 89% went into services and only 11% went to jail. So that was one of the key pieces we were looking for. But our collaboration with the Behavioral Health Crisis Center, with our community boards, and having that localized training and daily interaction allows us to do virtual calls. It allows us to say, hey, doc, can you come out to the scene, like we were talking about with the man on the bridge? We actually, one of our behavioral health officers went and got Dr. Sin and brought him out to the bridge, and he was there with him talking. Having that partnership and that communication makes all the difference. And I know that a lot of questions came about our manpower, and it doesn't really help. An example is a call like that, you'll get 3 to 4 officers having to deal with somebody, and probably a supervisor will show up. When our behavioral health officers show up, it's a behavioral health officer, a clinician, and the rest of the officers are sent to go back and start, working on crime issues. And they have the availability to spend, if it takes hours, talking to someone, finding them services, making the phone calls, doing all those pieces that a patrol officer just doesn't have time to do or doesn't have the reference to. And so it's a huge part of what the BHU does for with the clinician. And even in the off hours, we have officers that are trained the same as our BHU officers. So they're force multipliers, and they know how to handle things in the middle of the night if our 2 primary BHU officers aren't working. And so it's, to me, it's one of these paradigm shifts in law enforcement that, due to our increasing problems with mental health, the homelessness issues that every city's running into, that a lot have mental health background issues too. This kind of a paradigm shift is starting to look at things a different way, because up until now, we were continuing just to arrest people, put them into the jail, they would be released. They were never getting stabilized. They were never getting a chance to get into the services that they needed.
Thank you, sir. There are questions for the major from anybody on the committee? Now, seeing none, thank you, sir, and for your service and for getting this unit up and running.
Thank you, Madam Chairman.
Colin?
Afternoon, Madam Chair and committee members. I want to thank you for the opportunity to share our experience in Athens-Clarke County with the partnership between Advantage and Athens-Clarke County PD. So Athens-Clarke County PD created a crisis response unit in 2017, and the first co-responder team was established utilizing an ACC law enforcement officer and an Advantage fully licensed clinician. However, the partnership between Advantage and ACC actually started in 2015. Initially, baseline data was collected to determine the specific needs of the Athens-Clarke County community. There were 2 in-depth studies done in 2015 and 2017. The baseline data related to the number of people with a behavioral health disorder who were in jail was collected, in addition to arrest and booking records that were compared with Advantage client records, and criminal histories were reviewed using a jail database. As a result of the needs assessment and the in-depth studies supported the need for a co-responder team to respond to calls with suspected behavioral health concerns. The first team is available to respond to calls and provide training and police report reviews Monday through Friday, 8:30 to 5. However, in 2021, we had 2 teams operating full-time, and a 3rd team began in September, and they're scheduled based on high volume times. I want to share a little bit of data that we collected, and in 2021, there were 2,334 individuals reviewed against Advantage medical records to determine follow-up options. This is significant in terms of our ability to alert treatment providers of escalating psychiatric and behavioral health issues with clients that would not otherwise know about, we would otherwise not know about. This kind of information allows us to work more effectively to prevent crisis situations and to manage behavioral health issues before they escalate further. 876 individuals were provided with care coordination for needed services. I'd like to point out that individuals served by co-responder teams are not limited to CSB clients. These teams serve the entire community and often provide care coordination to individuals who are insured and who would otherwise not be touched by the local community mental health provider. 452 individuals were provided with outreach services, either in person or by phone, by the co-responder teams.
281 were in person, 171 were by phone. 237 mental health assessments were completed by the clinician co-responder while on a call with the police department. Only 16% of those assessments resulted in a need for a 1013. Co-responder teams also participated in over 100 community meetings, collaborations in 2021 with local organizations and businesses. When not on a call, co-responders made over 20 visits to local homeless camps to provide outreach and have been involved with local community groups helping to assist unsheltered individuals of the Athens-Clarke County community. Co-responder teams provided 52 training sessions for local community members, law enforcement, and interested parties statewide. This is an average of 1 training per week for the year. The partnership between Advantage and the ACC Police Department has demonstrated many benefits to the citizens of Athens-Clarke County by freeing up law enforcement to respond to criminal matters and ensuring individuals are connected to services, reducing the number of 911 calls for mental health crisis. Thank you.
Thank you. Are there any questions for the presenter from the committee? Thank you for your presentation. On Zoom, Sheriff Freeman. Sheriff Freeman, are you online?
I am, sir.
Please go ahead, introduce yourself and then begin.
Hey, members of the committee, I'm Ron Freeman. I'm the sheriff here in Forsyth County. Thank you for having us today. I get the privilege of being one of the last speakers, which means I'll be one of the fastest for you. I'm going to share a little something for you if I can, to take a look at just what we have done here in Forsyth County. Get right there to you. So in our first year of our mental health team, our crisis response unit, as you see, we've responded to 381 mental health crises. We've had contact with over 687 individuals. Here's a great part. Only 3 of those individuals out of the 285 field assessments that we went to ended up going to jail. I think that's important as we look at things. I think the other thing to make important note to you is, look, this is not a one size fits all. I run a really large law enforcement agency. We're the 3rd largest sheriff's office, full service sheriff's office, in the state. And why it makes great sense for us, and we're expanding to team 2 and 3. And I just got notice we received another grant to expand this into our jail, which will be team 4. It's in small South Georgia communities, it's going to be a challenge. And so Judge Sweat appropriately said that, look, some alternative resources will do that. I think by passing this bill and moving forward with this, I think what we do is we expose other law enforcement executives and this collaboration with mental health to find the opportunity that these things will work, that these things will save lives. I've watched our teams literally save a life. And so I'll share with you that it's not the panacea that's going to fix everything. It's not going to keep every mental health call from resulting in some potential use of force, because sometimes results are not what we want them to be, and we're faced with situations that don't. So I want to be clear on that. But 2, as again, the sheriff for one of the largest full service sheriff's offices in Georgia, we fully believe in this. We know that it's making a difference. And I think it's going to be important for sheriffs, and I've spoken with my fellow sheriffs, that we start looking inside the jail, not just on the 911 calls, but these people who are in jail, and overwhelmingly we deal with significant portions with mental health challenges, that we're providing resources to them as they get out so they don't re-encounter the criminal justice system on the next 911 call. So I think from those standpoints, look, it makes sense. It's costing us all in the state of Georgia money. We know that there's significant challenges in the mental health system in the state of Georgia. I know that members of the House and the Senate have been addressing that greatly this session, and I applaud you for doing that. And I will ask you to keep doing that, because I'm tired of being a mental health hospital at the Forsyth County Jail. And so is every other sheriff, and I think so is every member of the House and Senate. None of you want us to be mental health hospitals inside of our jails. This is the first step. This is the first step in how we do it. It's worthy of funding, because in the long run, we're saving money, and honestly, more importantly than anything else, we're saving lives by doing this.
Thank you for your presentation, and thank you to all your deputies and all that serve in some challenging areas. Appreciate y'all being open to new ways of handling a challenging portion of your job. And I know that's just a portion of it. Are there any questions from the committee members for this presenter, for Sheriff? Thank you, sir.
Thank you.
We do have several others to speak. Cindy Levi, you could introduce yourself and come to the podium. Welcome.
Thank you, Dr. Newton and committee members. Good afternoon, and thanks for the opportunity to share my support of SB 403, the co-responder legislation. I'm Cindy Levi, CEO of Avita Community Partners, which is the Community Service Board, or CSB, providing behavioral health services to the residents of Northeast Georgia. And along with Dr. Johnson, who testified earlier, a member of the Behavioral Health Reform and Innovation Commission. I present to you today with 40 years of experience in the mental health field and 20 years as a crisis intervention trainer for law enforcement. I'd also like to address you on behalf of the thousands of families whose loved ones live with a mental illness, like my close personal friend, Christine. Christine's son, David, is a proud graduate of UGA with a degree in economics, who aspired to a career in public service. A few years ago, while at home with his family, he experienced a psychotic break. Because of the concern for violence, his parents called the police for assistance. And when officers arrived, Christine explained that her son was experiencing a mental illness and requested that he be transported to a local hospital. Against his family's wishes, he was transported to jail, charged with a felony, and languished for over a week in jail without his medications. According to a report from SAMHSA, the Substance Abuse and Mental Health Services Administration, only 17% of individuals with a mental illness receive mental health treatment while incarcerated. The legal battle that followed, the money that was spent, and the heartache experienced during this horrifying event could have been avoided if only a co-responder team was dispatched to their home that day. Avita formed a partnership with Sheriff Freeman, who you just heard from, and his team of deputies in Forsyth County, with the goal of reducing incarceration of individuals experiencing a mental health crisis by assembling a co-responder team in the summer of 2020. Federal grant funding was obtained to support this venture. And the team composition includes a sergeant from the Sheriff's Department, a licensed mental health clinician, and a certified peer specialist. A certified peer specialist is an individual in recovery with lived experience who has had similar situations and experiences in their life and received specialized training to become a mentor and walk alongside of others experiencing mental health symptoms. In their first full year of operation, as Sheriff Freeman reported, the team responded to 381 calls for service, only resulting in 3 arrests. That's less than 1%. There were 285 individuals assessed by the licensed clinician, and 37 individuals did require an involuntary commitment for a comprehensive mental health assessment. A large majority, 248 of those calls, were resolved peacefully at the scene. And over 440 encounters were initiated to engage family members or caregivers to support their loved ones. And 486 connections were made to additional community supports. The unique role of the certified peer specialist is to provide follow-up after the encounter to ensure that the cause of the initial call for service has been diffused and the connection has been made to ongoing support and resources to avoid future law enforcement encounters. Over that year, 687 face-to-face meetings or follow-up calls were made to check on individuals following those encounters with law enforcement by Josh Bell, the certified peer specialist on our team. He also participated in 99 jail in-reach opportunities to assist with discharge planning with inmates identified with a mental health diagnosis for a smooth transition back to the community, therefore reducing recidivism. The use of grant funding for startup seed money made this possible. However, a longer-reaching sustainability plan for continuation of this service is needed. So I do respectfully request that funding is appropriated to support co-responder teams across the state. The team also provided over 1,100 training hours to the rest of the department on topics such as abnormal behavior, suicide prevention, officer resilience and wellness, mental health transports, teen mental health, and co-occurring disorders. These trainings prepare all officers for the possibility of an encounter with an individual experiencing symptoms of mental illness. Finally, I'd like to stress the best practice of partnering with a community service board as the clinical partners with law enforcement. The CSB staff are members of a much larger team that includes clinicians, prescribers, case managers, and peers that connect and provide a full continuum of services with consistency and continuity of care provided by the state's safety net provider. This partnership eliminates the risk of a fragmented parallel mental health system being developed, competing for scarce professional resources. Again, thanks for the opportunity to share this testimony, and thanks for your support of SB 403.
Thank you for your testimony. We do have a question from the committee, and we do have 5 others that want to speak to the bill. Chairman Dempsey.
Yeah, I just had one. Thank you. Thank you. And it's really good to hear from the CSBs and hear the commitment that is there as well, because this is intense. It's good. Don't get me wrong. I'm thrilled about it, actually, Dr. Watson. So thank you for bringing this forward. I had one particular question. I think you just mentioned a minute ago too, that contact within 2 business days that's in here following up, and that's so important. I think it's great. What are we going to do about people that are homeless, that sometimes leave, our jails particularly, and don't have a place to go? Are we going to intensify sort of that follow-up information?
Well, as you know, housing is a challenge across our state, and actually affordable housing is more of a challenge. And so to answer your question, actually, whenever a co-response team goes out, they make those connections in the homeless camps. And so in the example that I gave you, what would happen would be actually that certified peer specialist would then return to that homeless camp or wherever the individual was to provide that follow-up support. Now, one of the things that that he will do is assist them in finding housing. So that is one of the roles of that position.
Good. If I may ask again too, I really appreciate all the conversation that's going on about this. It's a very good, robust, positive piece of legislation, I would say too. I can see the great amount of work that's gone into it, and I do appreciate it. I just want to say thank you.
Thank you.
Chairman Hawkins.
Good afternoon.
Good afternoon.
Good to see you again. This is our Hall County connection here.
That's
I've
right.
got a question for you and possibly for the author. In the section of the bill, it says the emergency receiving facility shall notify the community service board prior to the release of the individual, whether or not the individual is admitted for treatment. Now, if this occurs late at night or on the weekend, do we have the ability to do that, or is there a central office that's called, or how does this work?
Yes, sure. So I can give you the example in Hall County since it will hit home.
Great.
So the Community Service Board last year opened a behavioral health crisis center, which is the emergency receiving facility for mental health. And so officers can take individuals right to that location And so they can receive the treatment, the assessment and treatment there. And then because they're already then enlisted in the Community Service Board services, then we can continue to follow them after they have stabilized from that crisis situation.
Right. So in other words, they're going to be diverted to your facility rather than the emergency room.
Correct.
Great. Great. Thank you.
You're welcome.
Does that receiving facility have medical capabilities as far as lab work and?
Yes.
Okay.
We work very cooperatively with Northeast Georgia Health System. So we draw the labs and they're a mile down the road from us. So it's very convenient. So we do get the results of the lab work quickly.
What kind of clinician orders those? Do you know?
Yes, we have an advanced practice registered nurse that is there 24 hours a day, 7 days a week.
Strong program. Go ahead. Yes, sir.
Everything's sort of local, right? We've driven, the purpose of this is to drive the community service boards, which are 23 in the state of Georgia, and everything is local. So it's different in Savannah than it is there. We have a residency program. There's a resident there 24/7 that is there, at that facility. And it is a crisis, stabilization unit also. So residency program, price stabilization unit, and the wraparound services that you get, and you get the follow-up. But I do want to stress that not everybody needs to go to the price stabilization unit. I mean, most of the time, it is not necessarily again, the statistics is that the arrests were at around 80 to 90%, dropped down to around 10% or less. And not everybody needed crisis intervention at that particular time. So, and 10% were 1013. So that's a really small number there also. So it is local, and it should be.
Thank you for your presentation.
Thank
No
you.
more questions now. Kim Jones, please come on up. And then after that, it'll be Jeff Breedlove next. But come on up, Ms. Jones. Okay.
I'm Jeff Breedlove, Georgia Council on Substance Abuse. Kim had to step away. She asked me to formally, for the record, say that Kim Jones, Executive Director of NAMI does want to go on record as being in strong support of this legislation. And NAMI wants to thank Chairman Watson and all the folks that have been working on this. And so NAMI did want me to stress
Thank you,
their
sir.
support. For the Georgia Council on Substance Abuse, I'll be very brief. I was thinking about what I would say back there as I was watching all the testimony, and some of you know me and some of you don't, but the privilege that I have is I'm a person in long-term recovery, and I'm a person who we're talking about, who y'all are talking about. I did have an encounter with law enforcement, and I was handcuffed, and there were restrictions on what their options were to do with somebody like me. And I have the privilege, I was thinking about this, it's a privilege for me to come up here because I've personally met with hundreds of my brothers and sisters around the state, in your districts and in every part of the state. And I know that the thoughts and goodwill of them go behind this bill, and that there are hundreds and thousands of Georgians that know about this bill and appreciate this type of innovation and leadership. Look, no one's asking that there not be consequences to our actions, but we are saying that when it's appropriate, that in many, many cases, it's medical help and medical treatment that's needed, not another statistic and another burden on our law enforcement officers. Law enforcement officers saved my life, but I didn't need to go to jail that night. I needed medical help that night. So, Mr. Chairman, you're doing work that impacts so many people, so many families, and we just urge support for this bill. And I would like to add one last thought. The good folks at the CSBs, the council has the privilege of partnering with them in so many efforts, and there's not a greater group of Georgians that can care for peers the way that they can. And I say, as a peer, we have every confidence in them, and we thank them for what they're doing in this process too.
Thank you for your presentation. Ms. Manny Naum. Mary, sorry. Ms. Zemke will be next. Go ahead and introduce yourself and proceed.
Thank you. Good afternoon, all. Thank you, committee, for hearing me today. My name is Mary Naom, and I work with the Policing Alternatives and Diversion Initiative, which is affectionately known by our local law enforcement in Atlanta as PAD. First, I just wanted to thank everyone who has worked so hard on this very important piece of legislation and to share PAD's support for the spirit and direction of SB 403. And today, I also just wanted to lift up just some important ways that we can continue in addition to this to be finding sites to build out and support our continuum of crisis care to just more effectively respond to folks who have behavioral health concerns. Just for some context, PAD has been kind of working on these issues on the ground locally since 2017. Through a partnership between the City of Atlanta and Fulton County, PAD collaborates with local law enforcement agencies to provide an immediate alternative to arrest for folks who are experiencing behavioral health concerns. So at the point of an arrest, PAD clinicians both meet officers at the site of that potential arrest to provide a supportive intervention. We then also work with the individuals who have been diverted from that arrest on a longer term basis through case management support services and linkages to care. As the chairman very astutely acknowledged earlier, the majority of calls coming into 911 are not for criminal concerns. PAD conducted a robust analysis of the Atlanta Police Department's calls for service data, as well as actively engaging in strategic discussions continuously with local law enforcement that supports this point. Locally, law enforcement recognizes that there are many calls where a non-police first response could be dispatched from the start as to not take away kind of critical police time and resources. So SB 403, we believe, would offer a critical stopgap where alternate crisis response resources are not available. And as state leadership considers investing more in appropriate and efficient responses to behavioral health concerns, I just wanted to lift up a few key differences between different types of alternate response. So there's co-response, mobile crisis response, and alternate first response, because they are all very critical to this continuum of crisis care. And just wanted to provide some support on that. So co-response, which is the subject of this bill, is when law enforcement and clinicians come out together for calls where there's a combination of an imminent public safety concern as well as a behavioral health concern. Mobile crisis response, such as the services offered through resources like the Georgia Crisis and Access Line, works hard to de-escalate a crisis over the phone through telephonic intervention. And then in more rare circumstances, when it's deemed appropriate by that clinician call taker, a mobile crisis unit may be deployed. Currently, though, GCAL's direct line is the only way to potentially access that mobile crisis alternative, and there's no way to reroute calls from 911 to GCAL. And then finally, the alternate first response, they deploy a clinical team through a 911 call center instead of police. So if you call 911, a call taker may ask you, do you need police, fire, EMS, or mental health response? So there are law enforcement agencies and 911 call centers across the country that are partnering with providers to implement such models because they save critical police time and resources by instead dispatching an alternate response team who have years of clinical experience and training to effectively de-escalate and assess and support folks with behavioral health needs. So PAD sees SB 403 as really the first step a first step in the important and really exciting process of transforming our emergency response system so we can really build safe, supportive, community-driven responses to 911 calls. So we appreciate your favorable consideration for SB 403 and would be happy to talk further about ways that we can continue to build up the crisis care continuum so we have all the right responses for the crisis needs that folks have. So, thank you.
Thank you for your presentation. No questions. Obviously, different communities have both different capabilities, but also very different needs. And thank you for your work.
Thank you.
Ms. Zemke and Terry Hawkins are online on Zoom. We are a little pressed for time. If you can condense your either support or whatever, go ahead, Ms. Zemke.
Hello, I'm Julie Zemke. I am the clinician that works on the Forsyth County Sheriff's Office Crisis Intervention Team. I'm an employee with Avita, and I think it's important to know that without someone like me on site that there is usually a wait of an hour and a half, 2 hours to have that assessment for dangerousness. And they're not able to have law enforcement or paramedics take them if they're not willing. And so that's a really key piece. I'm in support of this bill. If you have any questions as the clinician on the team for core responders, I'm happy to answer.
I don't see any questions. Thank you for your participation. Ms. Terry Hawkins.
Hey, thank you. Terry Hawkins. I'm a sergeant with Forsyth County Sheriff's Office, and I am the law enforcement member of our co-response team. I think the previous comments have summed everything up nicely. So I would just say I'm in favor of the bill and subject to anyone's questions.
I don't see any questions. Thank you for your participation today and for your work. That does finish all those who signed up online. What is the will of the committee? Representative Sharp.
Real quick, the great bill, everything I'm saying is great about it, but there's just one puzzle piece I think that is missing. Okay, that's really need to be considered. We're talking more of the law enforcement and the teams coming out, crisis teams, but I think even on your committee, someone in the EMS community needs to be involved in this, because a lot of the calls you get, maybe Uncle Willie, he's coughing real bad and he won't take his medicine. Now, it's very critical that that dispatcher can do a triage at that point to say who really needs to go out. The young lady just made the point about who needs to go out. So I think EMS needs to be involved, because a lot of the people, they call EMS or they call 911, the EMS comes out first. And then at that point, if you have a mental health patient or even a history of one, I think there should be a way that the crisis team has a great relationship with EMS so they can be called, versus if they get on the call and somebody's not acting right, then law enforcement is called first to say, hey, look, they're acting like this, because it's scene safety on the paramedic end to say, what do we need to do with this patient? Because we don't want to fill up the emergency rooms like we're talking, and then we don't want to fill up the jails when somebody can be involved. So I think what'll make this even better, or have it somewhere in your future of that step, you need to involve EMS in this, no matter what, no matter what, they need to be involved, because that's critical. And over 30 years of being in that profession, we get there first, and then it's like, what do we need to do? This is a crisis situation, but for us, a crisis is, okay, let's get law enforcement here to get this thing kind of, calm down a little bit. And I think this will help law enforcement side, but if sometime law enforcement may not be called, EMS is there, and it may just be, we don't need law enforcement. We see that this is a mental health crisis and we need that response team here as soon as possible, because once the call comes into 911 and everything that's going on, there is that golden rule, that golden hour rule, even with that person being in a crisis and getting worse by the time we get there. So I just want you guys to consider somehow, so we can get that on-site triage as well, to say, we need to have that partnership with, some of the other crisis centers. So just have that in your mind, because there's a lot of patients that are, that needs help in that area.
There will be a lot of building that has to occur. I know transport is addressed on 141 through 145. It does look like there's alternatives that can be discussed that would be safe and effective, but those are just allowed for and certainly not required. But I do believe that would, especially since it'd be non-government owned vehicles, I think that's an option you prepared for. Is that correct?
Well, there are some places that use an EMT as a part of a team. It's often part of a civilian response team. We're building one in Athens that will have an EMT, and EMTs can play a critical role. I think we're going to see what develops in communities, but we recognize the need to have that professional experience in some circumstances. So we're certainly keeping that in mind. So thank you.
Chairman Gaines, did you, or
at the appropriate time, have an amendment?
Oh, we'll get to that in just a second, sir. Chairman Hawkins, Chairman Hogan.
Thank you for this bill. I think it's a great start. I just think we need a lot of help in South Georgia, and keep bringing this bill out and BDHDD, where do they stand on this with possible funding from them?
Well, they haven't taken a formal position. DBHDD has announced working on a couple of pilot programs, but they are, I don't think they're in opposition to it. They have not really made a statement as I know. Chairman,
Yeah, I mean, this is, so community service boards are under DBHDD. That's what I had alluded to initially, and they're certainly not opposed to this bill by any means. And I think, they're not mutually exclusive to 1013 either. I mean, if they both go simultaneously, they both get rolled into one, they both, pilots. I mean, it does seem like we have, I stand corrected, 9 of these going on, and they're all different, and as they should be, whether that's a rural area or whether it's Forsyth and more urban area, or Fulton County, even more urban. That's, and as with funding, you just passed the budget last Friday. That does have some budgetary money in there related to that, and we're going to be looking at the Senate, and we're actively discussing this as of this morning.
Mr. Chairman, jail population, and I understand the testimony that jail population has been decreased substantially. We've had a lot of deaths in our jails, community jails and the state prisons. And these are mental health folks that are being killed and are committing suicide. And I don't know where you've kept up with statistics on the number of deaths we've had in our county jails, but it's unbelievable. And the mental health folks have no business even being in these jails to begin with, but they are dying in them. I've just had a death in Brunswick about 3 months ago of a young guy that's schizophrenic, and that his roommate beat his head into the cement and killed him. And then we've had several suicides. So it's a disaster out there in our county jails. And if this decreases the population in the county jails, I'm all for it. I think it's a great
Well,
bill. Thank you.
You certainly, Major Gavin, Sheriff Freeman, and in my community, Sheriff Wiltshire latched onto this because as Ron Freeman said, that, his facility was becoming more of a psychiatric facility. And you heard the statistics. And let me just leave you with this. 90% were arrested in some jurisdictions. That changed to 10% arrest rates. You're talking about 1013s down to 10%. So, I mean, that's a startling statistic, and you're getting people to the right place in a crisis, undergoing a crisis.
This bill.
Thank you. That Representative Hutchinson online on Zoom.
Thank you, Mr. Chair. I just wanted to give a statement of support for this bill. Co-responder teams has always been a phenomenal model for best practice and in research. And to see that this is moving forward when we still have 1013 still over in the Senate is very encouraging for mental health professionals. And I am really glad to see this. This will make a big difference in practice and not just in policy. So I really, really appreciate the authors. And at the appropriate time, I will second the to pass.
Now's the appropriate time to make a motion.
Do we have a motion to
I have
pass?
a motion in a second.
Yes.
All right. Thank you. We do have an amendment. Chairman Gaines.
Thank you, Mr. Chairman. I have amendment 332006, which should be in everybody's folder at the request of the author. An amendment that cleans up some language that was added on the Senate floor and the Senate floor amendment on line 63, inserting the words "from civil liability after immunity," and on line 78, inserting "from civil liability after immunity." And that's the amendment.
All right, we have an amendment and is there a second? We have an amendment and a second. Is there any discussion on the amendment? Hearing none, all in favor of the amendment AM 332006, say aye.
Aye.
Those opposed say no. All right, the amendment passes. Now we have a motion and a second on Senate Bill 403 as amended by this committee. Is there further discussion on the bill? If not, all in favor of SB 403 as amended, say aye.
Aye.
Those opposed, no. The bill passes. Thank you for your work on this. All those that did. Thank you, sir.
And the chair
Chairman.
lady, I think, has agreed to.
Chairman
carry
Cooper
it.
is going to carry this in the
Yeah,
House.
right.
Strong answer. Thank you all. I believe thank you for all online who participated. We're adjourned.